This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hi, this is Dr. Deepak Megur. I am here with a challenging case. This is a Phacomorphic lens-induced glaucoma in an 85-year-old gentleman who has pseudoexfoliation, a swollen lens, and a very shallow antechamber. And to add on, he has got a moderately dilating pupil. The pressures were consistently high for the last 1 week, and with maximum medications and IV mannitol, the pressure is now 18 just before surgery. The cornea is not great. We have got a thick arcus and overall visibility is not great. And this is the anti-segment OCT picture. The chamber is shallow and then the axial length is 21. So we've got multiple challenges to deal with. First of all, we need to deal with the pupil. Next, we need to deal with the anticapsule, get the rexus right because it's a swollen lens. And then we need to address the zonular health if at all there are any. The nucleus management is not going to be much of an issue. So let's start. Surgery is being done under a peribulbar block massage, which ensures that the eye has become relatively softer now. We also had given pre-op IV mannitol, 300 ml. Now before making the incision, I'm just checking the pressure of the eye. The eye is soft. Time to make the first side port incision. So I'm using an MVR blade to make an incision. I'm just very mindful that I don't perforate under the iris the anticapsule. So I need to be gentle and I need to orient the blade in such a way that we don't puncture the anticapsule. Now because the chamber is very shallow, it would have become still shallower of the first port. So I'm avoiding creating the second port now itself. So I want to do the second side port after putting OVD. Before that, the capsule needs to be stained with trypan blue under the air bubble. Because we are dealing with an intermittent white cataract, capsular staining becomes very critical. So I'm just waiting for about say 10 to 15 seconds for it to stain well. Then the dye is irrigated out. Once the dye is flushed out, time to fill in the OVD. I'm using a soft shell technique in this case. The first OVD to go inside is a dispersive OVD followed by the cohesive OVD, that is a sodium hyaluronate under the dispersive OVD. Once the chamber is deep enough, I'm going to create my second side port using the same MVR blade. Time to create the main incision. The globe is stabilized. I prefer to turn it slightly away from me. A posterior limbal groove is created and then a 2.8mm posterior limbal based incision is created. Now is the time to insert the pupil expansion device. In this case, I'm going to use the B-OCTA pupil expansion device. One modification which I'm trying out in this case is instead of the flange being anterior to the iris, I'm trying to see how it would work by placing the flange beneath and the W's of the device on the anti-surface. So I'm holding the flange with the forceps and then engaging the notches. By doing so, the flange has gone behind the iris and the W's are on the anti-surface of the iris. By doing so, there is not going to be much of a change in the pupil dilatation, only the device would be looking differently intraoperatively. Now, because the chamber is very shallow, I need to be mindful that when I'm trying to maneuver the device, my forceps or the device doesn't puncture the anticapsule, because we need to recollect that the chamber was extremely shallow because of the swollen lens. The third pair of notches now is being maneuvered and I'm holding the flange here with the forceps. The globe is stabilized with the second instrument. It would help us to prevent the globe turning away when you're trying to negotiate the device, especially in this rigid pupil. The hands are switched and the last pair of notches are to be engaged. Now, in such eyes where the visibility is bad because basically the cornea itself is unhealthy, we have got a very thick carcass and a very small space to maneuver. Engaging the last piece of notches can become a little bit of tricky. So we need to have a higher level of focus. So one trick which I do is I turn the eyeball slightly away so that the B-OCTA device, the flanges become visible. Because the color of the BX or the B-OCTA and our Indian brown eyes, they match so much, sometimes we may have difficulty when the visibility is compromised, especially in elderly people who have a pseudoexfoliation and a shagreen degeneration of the cornea, thick carcass, the engaging the last pair of notches in a rigid pupil can become tricky, especially for the novice surgeons. Nevertheless, now we have excellent pupillary dilatation with the B-OCTA. So the pupillary issue is totally out of the way now, and now is the time to just focus on the job at hand. Time to perform the rhexis. The capsule is punctured with the 26 number needle. You can see some passive egress of liquefied cortex. Well, this is a good sign. Whenever we see this, the chances of the rhexis extending to the equator are very minimal. The capsule is folded on its own and the tearing begun. I'm trying to be very watchful to observe any wrinkling of the anterocapsule at the edge of the tear. The presence of the folds during tear would suggest a significant zonular weakness. So in this case, it is not a major concern. Now, before completing, I felt that the chamber is getting shallow. Come in and I inflate the chamber. Mind you, I am placing the OVD on top of the anterocapsule, not under it, so that the pressure within the bag is not increased. The last lap of the rhexis is completed. So now we have a decent sized capsular opening. Now, getting up to this stage was a little bit of a challenge. As we are able to see well the rhexis is done, managing the nucleus is not going to be difficult at all. So this is a mature cataract, and usually I avoid hydrodissection in such cases. I'm directly going in with my phaco probe. The superficial epinucleus and the cortex is being aspirated out. But as the superficial epinucleus is aspirated out, to my surprise, there's an underlying nucleus is relatively brown, so indicating it's a dense cataract. So I was fooled by looking at the color of the cataract. I thought it would be having a softer nucleus, but no, it is quite a dense cataract. So to begin with, I create a small central trench by using the continuous torsional energy. So once we have around 40 to 50% depth, now is the time I go back and start my vertical chopping technique. The tip is buried into the substance of the nucleus. The chopper goes down vertically and then there is a lateral separation. The patient is a little bit uncooperative. He's moving his head. Just we need to counsel him a little bit, talk to him, and then I'll be back with the surgery. The OVD is refilled into the chamber. The nucleus division is continued. I can see a central focal area of corneal edema, which was pre-existing, and that's one of the reasons why the visibility is not great. The nucleus division is going to be a little bit challenging. Only thing is we need to be patient, and what you can see is the chopping maneuver is being done in multiple smaller maneuvers. That is, first the chopper does the initial crack, the posterior plate is not yet separated, the chopper goes down vertically and then does the lateral separation maneuvers a couple of times. So this we need to keep in mind, especially when we are doing this denser cataracts. Eventually the posterior plates will give way. Only thing is we need to position the chopper progressively deeper, very near to the posterior plate. Now all the fragments are divided. Now is the time to emulsify them one by one. So after the first couple of fragments are emulsified, time to refill the chamber with OVD and then resume the emulsification process. Simply because gives an added protection to the endothelium as we're dealing with a very dense cataract. Fragment is pulled out of the bag and then emulsified. As I'm emulsifying, my left hand is placed above the nuclear fragment just to control the turbulence and prevent any lens particle jumping out and hitting the corneal endothelium. So the last piece is out. There is an epinuclear chunk which also gets aspirated. So you've got some amount of cortex there and it needs to be aspirated using the bimanual aspiration system. The cortex is aspirated, and now is the time to implant the lens. But before the implanting the lens, I thought I would go ahead and insert the CTR. The bag is filled in with OVD and the CTR is threaded into the bag. The patient is elderly, there is pseudoexfoliation, there is mild zonular weakness, not significant, but still I would prefer to go in and place the CTR. Time to place the planned multi-piece lens into the sulcus. The trailing haptic is dialed into the bag, the lens is secure in the bag. I'm just trying intraoperative gonioscopy now just to see what is the status of the angle at this stage. The cornea being very hazy, the visibility is not so great, but in one quadrant I see that the angle is open and that should help. So I'm expecting the pressures to be under control because of the lens extraction later on. So let's see how things turn out. With the OVD still in place, I'm just removing the B-OCTA. The notches are disengaged and going to the main port. The device is held with the forceps and pulled out. And inserting and removing the B-OCTA is as easy as the B-hex. So no issue with that. OVD in front and behind the lens is aspirated out. Time to close. The side ports are hydrated. The main incision is hydrated. That's it, the case is done. Now these are the first day post-op pictures. These are the fourth day post-op pictures. And these are the OCT findings. The anti-segment OCT clearly shows that we have a very deep chamber. The angle is opened up considerably and the pressures are under control and the anti-glaucoma medications are slowly weaned off. So this was a challenging case. We had a shallow chamber, an intumescent lens, a poor visibility, and the pupillary issue was dealt very well with the B-OCTA device. Now this thin profile of this device comes in very handy when we are dealing with such shallow chamber eyes. There's hardly any space for maneuvering and any bulky device is going to be tricky to use this. Now the significant advantage of the B-OCTA, as was with the original B-hex, is a thin profile. Because it is thin profile, maneuvering it inside the chamber is extremely easy and the technique of inserting and explanting obviously is very easy. But the biggest advantage is that it gives a significantly better dilation compared to the B-hex. So because we could see well, this complex surgery seemed as routine as it could be. So that was it. Thank you for watching and hope you found this helpful.